I would like to acknowledge at the top of this webinar the historic and ongoing impacts of colonization on Indigenous peoples in this country, including the unique and often invisible intersection with sexual orientation, gender identity, and gender expression change efforts, as well as the racist systems and institutions that continue to marginalize Indigenous peoples today. We at CBRC are committed to supporting truth, justice, decolonization, and reconciliation as an essential part of equity and inclusion for two-spirit, queer, trans, and non-binary people. I myself am joining from Toronto, which is on Treaty 13 territory, the unceded and unsurrendered lands of the Wendat, the Anishinaabe, Métis, and the Mississaugas Credit First Nation. I, as the child of immigrants from Ethiopia, take very seriously the commitments that I have and the responsibilities that I have for the treaties and the Dish with One Spoon covenant that covers Toronto. And I hope today that you will join me in taking a moment to reflect on the lands that you are listening and calling in from today as we go through this important work. And now I will pass it over to Nathan Lachowsky. So Dr. Nathan Lachowsky is the research director at the CBRC and the principal investigator of the Sex Now survey. He is also an associate professor in the School of Public Health and Social Policy and Michael Smith Foundation for Health Research Scholar at the University of Victoria. Nathan, take it away.
Thanks, Naomi, for that introduction and for getting us started today and for spending the time with me and the rest of us. Thanks everyone in the audience for taking some time out of your day to come and hear a little bit about some of the data from Sex Now 2021. I'd also like to start with just acknowledging the territories that I'm calling in from today. These are the lands of the Lekwungen people, the Songhees, the Esquimalt, and Wasanich nations, what's known as the south part of Vancouver Island or Greater Victoria. And I think a lot about that, particularly of late in the ongoing war in the Ukraine. And on my father's side, I have Ukrainian heritage. He was born in Europe and immigrated to Canada. And then a lot of our extended family, basically all of them, followed in time. And so the safety of our family is in direct result of the displacement of Indigenous people and the ongoing settling and colonizing of Canada. So I've been reflecting on that quite a bit lately. And also have been reflecting for many years based on many of the teachings and the prompts and the advocacy and the activism in our community to try and think about ways for us to improve our work here at CBRC and our research in particular in relation to Sex Now and how that sits for Indigenous folks in our communities and how that sits for Two-Spirit people. And so we've been doing a lot of work over the past 3 years to increase the accessibility of the survey, to increase representation and visibility of Indigenous identities, ways of being, and realities and factors that are important as determinants for health and well-being for those communities within the survey. So I'm not going to be focusing a ton on that today in terms of these data, which are really a high-level overview of the whole sample, but they are data that exists and they're data that we're working through in partnerships with different people across the country, and also trying to share our lessons as researchers in the journey that we've been on in the hopes that other folks in the sector can also improve their work in those ways. And certainly it's not done for us. We know there's lots of work that's left to be done as well. So without further ado, in terms of this webinar, we're really fundamentally kind of focusing on some of the data related to combination HIV prevention, and in particular, antiretroviral based prevention. So Kiffer Card and a few others of us at CBRC drafted this scoping review back in 2018-19, a time before COVID. Focusing on providing this kind of a 20-page summary of combination prevention. Where did it come from? What are some of the key elements of it? How is it practiced in our field? And with a particular lens for a focus on our communities of gay, bisexual, trans, queer, and Two-Spirit folks. And so if you want a little bit more background on combination HIV prevention, this is a really great resource that kind of summarizes across a whole bunch of the seminal documents in the field. And it's available as part of the scoping review series at cbrc.net. So I encourage folks to check that out. So we'll be talking about, in terms of today's webinar, a little bit about U equals U, particularly in the context of increasing PrEP use, about substance use, and about HIV self-testing. And those were all pieces that we focused a little bit more on, or a little bit more deeply on, in Sex Now 2021. And so that's why we're here sharing the data back. So in terms of Sex Now overall, many people I'm sure are quite familiar with it, but it has been an ongoing national survey for during more than 2 decades. And it really is evolved over that time. So it originally started as being defined as a survey of sex between men. And we've been kind of expanding that that narrative and the inclusion for the study over time. So it's for self-identified men or non-binary folks, as well as two-spirit people. And we have done in-person and online recruitment. Obviously, with COVID, we've been restricted quite a bit for the past few years. So 2021 and 2020 and 2019 were all conducted online. And that really uses a mix of advertisements that are on during different social sexual websites and apps like Squirt and Scruff, but also community-based organizations outreach, whether that be via their social media or email lists or other mechanisms. When we have done in person, which we have started again this summer, we largely recruit from Pride Festival events and other community venues or events that are going on identified by local partners. And so we'll be sharing a little bit of data in today's presentation from 2018, which was the last time we were in person before the summer. And in terms of other eligibility, folks have to be at least 15 years of age. They have to live in Canada and either have a non-heterosexual identity in terms of their sexual orientation or have a behavioral report of sex with a man in the past 5 years. Women aren't eligible for sex now and have been during over the course of the period that we're sharing all of these data. So that's kind of the overview of Sex Now, if that's new to anyone. And in terms of 2021 specifically, so there's one of the advertisements from the study is here on the right-hand side. And you can kind of see Sex Now 2021 paired with Test at Home. So we added this option in Sex Now 2021 where people could opt into receive some HIV self-test kits. And so these self-test kits were newly available in the country, and we gave people the option, regardless of HIV status, as long as they were 18 years and above, and that 18 threshold was because of the Health Canada approval of these test kit devices for that age range. And so they could request up to 3 test kits that we would then ship to them that they could use themselves or they could share with somebody else. We also in 2021 added a few additional languages. And so the survey was run in English and French. That was about 90% of the sample completed in those 2 languages, which we've had in Sex Now for many years, thanks to Olivier Ferlat and others in terms of making the survey bilingual. But this cycle, we also added Spanish, Punjabi, and then traditional and simplified Chinese. And we did have a portion of participants who completed in all of those languages. We learned a lot about trying to run a survey in those many different languages. And we leaned on a lot of people within the broader network of CBRC and our sector to be able to ensure we had language kind of expertise to help with testing those translations, as well as importantly with outreach. And so we're learning lots about the kind of aspects of providing multilingual access to research. It's part of our commitment to try and increase accessibility of Sex Now. And there's certainly a lot that we can continue to do to improve. And so always open to feedback on that piece, but hoping that we can continue to have conversations during different parts of our communities about what makes surveys accessible and available to folks. And so in 2021, we had just shy of 6,000 people complete it. So that's kind of the rough number for the data that we'll be showing back today. So that's a little bit about the method, so kind of where the data comes from. And now a little bit about who are the folks that actually participated. So what we'll see over the next 2 slides are some different descriptors of the demographics, really, of folks who are in the study. So a range of ages. In general, with the online recruitment, we don't tend to reach a lot of folks who are 60 and above. So just over 10% of the sample aged in that category. And 13% of the study were in rural or remote geographic areas as self-defined by the participants. And a quarter of folks had high school or less in terms of formal education completed, formal Western education. And then in terms of HIV status, 7% of folks self-reported living with HIV. And that number is sometimes a little bit low, especially because we often have a lot of studies that are based in urban centers where during the prevalence of folks living with HIV is a lot higher. And I think one of the things that we're learning also is when we pair these kind of testing options with our studies, that often has some folks who are living with HIV feel like it's not intended for or inclusive for them. And I just want to make sure that people are aware that during Sex Now is always open to folks of all HIV status, whether you're aware of your status or not, whether you know that you're living with HIV or you know that you're HIV negative. The study is open to everybody. And in this case, we really believe that there was a role for folks living with HIV to play, also in terms of understanding how HIV self-testing is affecting our communities, and also potentially acting as secondary distributors. So during passing those self-tests on to other people. Folks living with HIV know a lot about HIV and know a lot about treatment and a lot about during various aspects of living with that infection. And so we really see it important in our work to make sure that there is space and recognition for the role of folks living with HIV. And then on the left-hand side here is a simple one question that we use to kind of assess financial hardship or strain. And so people are able to respond about what's your current money situation. And those are the four kind of response options on the left-hand side. And so what we see here is you're in a third of folks basically being comfortable with extra, a third having enough but no extra, and then the rest of the sample having during challenges in terms of needing to cut back or not being able to make ends meet. And this again is important during, these are demographic factors, but they also reflect some of the realities of social determinants, in particular how COVID has impacted parts of our community differently in relation to access to resources and supports. And then the next slide here is, again, a little bit more about demographics. So on the left-hand side, folks can select a variety of sexual identities. We still have about 2/3 of the sample who are identify as gay, but a variety of other identities are also selected by the participants, and you can see those reflected there. Ethno-racially, I've listed these alphabetically in terms of some of the different ethno-racial groups around responses. This is something that we're constantly kind of paying attention to and trying to make sure that we think about. Again, I talked a little bit in the intro in terms of my acknowledgement into some of the work we've done around Two-Spirit communities. But this is also something that we're doing more broadly as we think about what's the role of Sex Now in providing data to help advance anti-racist agenda and action. And then in terms of trans experience, 8.8% of the overall sample reported during trans connection or trans identity or trans experience. And then the gender identity during some of the various groups are listed there. So 85% identified as men, 3.8% were trans men, 4.5% were non-binary, and 6.4% selected some other gender identity, whether that be agender, et cetera. So that's a little bit about who is in Sex Now. And now I'm going to take you kind of through 3 different chapters of results. So this first chapter of results is related to the test at home piece. So the optional HIV self-testing aspect of the study. This is again one of the visuals from the advertisements. Many compliments to the CBRC comms team for their support in putting all of these things together. And so, as I said kind of earlier, that Canada approved our first HIV self-test late in 2020. This was spurred on definitely by the impacts of COVID. And we were really wanting to make sure that there was access to testing because we were hearing quite a bit of challenges to shutdowns of sexual health clinics, deprioritization of these kinds of health issues in the grand context of trying to respond to the COVID pandemic. But it also, this work was really led by the CIHR Reach Nexus because we have not had access to these technologies in Canada, despite the fact that there are many HIV self-tests that are approved for use in several other countries in the world. And so Canada has been behind in this regard. And so we wanted to be able to run Sex Now 2021 as an opportunity to help get the word out about HIV self-test, but also see who in our community was interested in participating in that aspect. And so folks, again, could do Sex Now, and if they wanted, they could opt into the test at home component, where we would give them up to 3 free HIV self-tests. And then they completed a series of follow-up surveys for up to 6 months after the initial Sex Now 2021. And those 6 months follow-ups actually just completed a few months ago. So we're still doing data collection and linkage and cleaning. So I won't be talking about any of the follow-up data today, but that will be something that we'll be able to report on later this year, hopefully at Summit, which all of you I hope will be attending. So in terms of the test at home uptake, we had over half of the participants opted in to test at home. And of those, 10% had never tested for HIV before. So during really thinking about the kinds of groups that HIV self-testing can help reach and potentially engage in HIV testing, and really thinking about these testing devices as an engagement strategy for connecting with people and helping to provide an opportunity to share information, connect to resources, provide education, et cetera. It's not just about the test and the result itself, although that's important information for an individual. And of course, we want to make sure we provide people with support and linkage to appropriate resources as necessary for that. But that's one of the kind of key pieces of who we've talked about sometimes in terms of HIV self-testing can help with. We distributed a total of 5,400 HIV self-tests. And so most people were requesting 2 to 3 test kits in total. Some folks only wanted 1. And so then we looked at who was more likely to opt in to the test at home study. And so there's a number of factors here with the numbers shown in red for the percentage of folks that have that characteristic that were in test at home compared to the number in blue, which is the characteristics of those who decided not to do test at home. So what we found is that those who opted into the HIV self-testing component were more likely to be younger, to have experienced financial strain, to live in an urban core, to have been born outside of Canada, to report having a disability, to identify as a person of color, to be single, and have a HERE score of greater than 10. And so that HERE score is the HIV incidence risk index, one of the kind of indicators for PrEP access in the national guidelines for PrEP. And so in general, there's a lot of things there that kind of speak to positively to who HIV self-tests can reach. And so when we're thinking about outreach and initiatives that are trying to reach certain parts of our communities, it seems like HIV self-testing was of interest to a number of those. I do think there's some conversation around geography. So just to point out, folks in urban cores were more likely to report an HIV self-test or to participate in the HIV self-test component than those who were not. And so I think during this aspect of how beneficial HIV self-test can be for geography is something that I think we need to explore and dig into a little bit more, because often we talk about the fact that testing and testing services, already the greater access tends to be in the urban core areas as well. So that's something that I hope we can look at a little bit more later as well. And so in terms of acceptability and use, just in terms of distribution, 70% of the test at home participants who completed some of these follow-up surveys, as I said, it's not all of the data yet, but this is just an initial pass. 70% of them had distributed the self-test to somebody else. And so I think this really speaks to the fact that our community is networked, is connected, and that people are often sharing information and resources. And so we expected that within the study, and wanted to be able to kind of measure and understand how much that secondary distribution occurred. So we can give HIV self-tests out, but then where do they go after that? So that's something we'll be following up on more as well. And then in terms of acceptability, Adrienne, nearly 90% of folks rated the overall experience as good. Nearly 90% found the kit very or somewhat easy to use, and nearly 90% said they would be very or somewhat likely to do it again. So pretty happy with the general satisfaction that participants reported around the study. And in terms of the greatest benefits, folks said during that was really related to the fact that it was more private and more convenient than going to a clinic. So things that we would have expected out of an HIV self-test versus traditional clinical testing. And half of our participants didn't see any drawback to the test at home process. So kudos to the team, Chris, David, and others who helped put that all together. So in conclusion, around the HIV self-testing pieces, during uptake of the self-test was high, over half of the participants in the study, and many wanted to receive multiple kits. And it was also fairly common that folks distributed those on to other people. The mail home self-tests reached many, but certainly not all of the groups that might benefit most from this new technology. And again, I think that's something that we need to delve into a little bit more as we go forward and think about HIV self-testing implementation. And that we will have additional data coming shortly that we'll be able to look at a little bit more about what the impacts of this has been and both in terms of results of HIV self-tests and as well as linkage to care, and thinking about what feedback we get from participants about how to design these programs in the future. So that's the kind of pass around the HIV self-testing. So the next chapter is around substance use. And so we had a few additional questions in Section 2020-21 specifically focused on substance use. And I think just to foreground, I mean, we know that COVID was still ongoing during the period of the study. That's why it was online. That's why we provided the access to the home kits. And so we know that to some extent, these data represent the realities of that point in time. And that's why the value of sex now occurring year over year is so valuable, because it does help us look at what changes over time, and to some extent pulling apart what was COVID and what might be other trends that are happening in our communities. But nonetheless, this is kind of what was going on for substance use for our community in 2021. And so probably shocking no one, substance use is common across our communities. And that really is regardless of gender identity or ethno-racial identity or HIV status. And there are a lot of different motivations for using substances. The three most common or top motivations that were reported across communities were to feel good or better about situations, to help with life difficulties, and to connect with others. But most people selected multiple motivations, showing that there's no one single motivation that people have for using substances in our communities, and that both the motivations and the use of substances are complex. In terms of what substances folks were using, alcohol and marijuana were the most widely used, but poppers, psychedelics, and cigarettes or vaping were also prevalent in the community, and they varied across different parts of our community as well. So we asked about use in the past 6 months, and the two most common ones, as I said, were alcohol and marijuana. During 4/5 of the community reporting alcohol use and half of folks reporting marijuana use. And you'll remember this is after marijuana sales were legalized here in Canada. But we also know that banned substances like poppers, which were reported by 1/3 of the community, continue to play an important part in our lives, and especially amongst those folks who are living with HIV, where we had half of folks who were living with HIV use poppers in the last 6 months. And in terms of specifically substances and sex, so June 1 and 4 participants reported using substances within sexual settings and to enhance their sexual lives. And there's it didn't vary largely actually across age or gender or ethno-racial identities. Most people reported that they did it once in a while rather than a weekly or daily practice. And the most common substances used during sex were poppers, marijuana, and alcohol. And during one of the differences we did see was for folks living with HIV, who were more likely to report using substances in a sexual context, and most likely to report poppers, meth, marijuana, and GHB as the substances used. So some differences here in terms of our community, and important for us to think about as we design during substance use supports and services and access to harm reduction. So when we think about some of those pieces, the need for substance use related services do vary, and those who seek them out still certainly reported barriers to doing so. I think one important piece here is that half of the community who use substances were not actively seeking to change their substance use. And I think that's a really important piece in terms of thinking about how we meet people where they're at and how they feel about their own substance use. And for those who did want to reduce or quit a substance, doing counseling and healthcare providers were some of the things that they identified as most wanting or needing. And specifically amongst those in our community who use opioids, crystal meth, or injection drugs, there was a need for better access to harm reduction supplies, as well as naloxone or Narcan kits. And about 1/3 of those who use injection drugs wanted specifically access to needle exchange programs. And I think that really speaks also to this aspect that while these programs may exist, they are not always seen as accessible or available to our specific community. And so we need to improve our access to these things. And I know many people in the community are doing that, especially at a local level with various kinds of services and supports. But we also need to make sure that what services exist are not just by our community, but that if there's other service providers providing substance use supports, that they also do cater to and support the realities of our community, which means they have to account for the diversity of ways that we use substances and the motivations we have for them. And so that really means taking a sex positive, queer and gender affirming approach to providing substance use, harm reduction and support services. So that's the chapter on substance use. And then the last chapter here is about temporal trends of U equals U by HIV PrEP status. And I'll explain that a little bit further in a second. So many of our community organizations were the first to endorse U equals U in Canada, and the country officially endorsed it in 2018. But we actually don't have a lot of data that has measured during what's happened with U equals U over time. Again, one of the strengths of Sex Now is that we've been running it for many years. And so we can actually look at how some of these things are changing. So this part of the presentation is actually going to draw on data from before 2021, and we'll show you some data as how things have changed over time. And so that's really what we're calling these population level trends. So what's happening for the overall community over time. And we're going to divide or separate the community trends out by HIV PrEP status. So we're going to have one group for folks living with HIV, one for HIV negative folks on PrEP, and one for HIV negative folks not on PrEP. So if folks are interested in the kind of analytic details around this piece, we're doing these analyses using multivariate logistic regression by those 3 HIV PrEP status groups. And we use survey year as the continuous measure, as the primary explanatory variable. So what we're thinking about here is during the outcome being knowledge or a practice related to equals U, and then our main explanatory variable is time. And so we control in these analyses for age, education, ethno-racial identity, and sex and gender identity. And when we have behavioral outcomes, we're also controlling for the number of recent sex partners. And we do that to try and adjust a little bit for the impacts that we know COVID has had on the sexual realities of our lives. And so what we'll show here, again, you can just look at the figures and the lines, but if you do want to think about the trend significance, then we'll show that in terms of odds ratios and adjusted odds ratios with 95% confidence intervals. So where those are bolded or highlighted in the box, those ones were significant. And I'll talk you through those over the next few slides. I promise that's the only stat slide. Okay, so in terms of these various years, so we have data from 2015 all the way up to 2021. And what you can see here in the red boxes are folks who reported being HIV negative and on PrEP. So only 1% of the sample in 2015 reported that. You can see that increase quite dramatically up to 2020 and then decrease a little bit in 2021. In blue are participants who were HIV negative but not on PrEP. And again, you can see that was highest in 2015 and that decreased over time. With a little bit of an increase in 2021. And then folks living with HIV in orange, generally on average about 8% of the sample. So in total, this represents about 24,000 responses from folks in our communities over the past 5+ years. And so one thing just to highlight about this, the one year that kind of stands out as a little bit different from the others demographically is 2018. In 2018, as you might recall, was a year that we were in person doing Sex Now. So all of the other years of data come from the online recruitment. But in 2018, we were at Pride Festival and community events, and that demographic largely is a little bit younger than some of the other ones. So just one thing I wanted to highlight, but as I did mention, the trend analyses do control for age, as well as a number of other demographic characteristics. So let's look at what's changing over time. So this first piece here is a question about knowledge. So we asked people if they knew medications taken daily by someone living with HIV can make their HIV viral load undetectable. So what we can see here is back in 2015, the knowledge around this didn't really vary by HIV or PrEP status. Everyone was hovering around 70% of the community being aware of this aspect around treatment, making folks undetectable. And that really changed quite dramatically from 2015 as we move forward to 2018 and onwards. So folks who are living with HIV, 100% in 2021 were aware of this. During 97% of folks who were on PrEP and HIV negative were aware of this by 2019 and 2021. During what we see here is that for folks who are not on PrEP, during the knowledge lag behind, still a majority of folks not on PrEP aware of this, but certainly much less than the other two groups here. And all of these significantly increased over time. The next knowledge item was knowing that undetectable equals untransmittable and that we have scientific consensus on this kind of fact. So we started asking this question in 2018. And what you can see here again is that all of these increased significantly over time. And again, folks living with HIV have the strongest knowledge around this. During folks on PrEP, it's just slightly below that. And then folks not on PrEP, during, again, lagging behind in terms of those other groups. So now we're going to switch from knowledge a little bit towards behavior. And so we asked folks in the past 6 months, have you had any anal sex with an HIV positive undetectable partner? We've asked this since 2018 in the study. What you can see here, do you know what I mean, is generally not a lot of change. So for folks living with HIV and folks not on PrEP, we didn't see a significant change over time for this. We did see a significant decrease over time for those who were on PrEP in relation to the proportion reporting this behavior. Excuse me, just needed some water. So the next behavior here is whether they reported having any anal sex with a partner whose HIV status was different than mine. What we can see here are two significant trends for the HIV negative group, both declining over time. So this, I think, speaks a little bit to the idea of sewer sorting and how prevalent it is within the community. So this figure is a little bit messier in terms of the numbers bouncing around a little bit more, but we do generally see an increase over time for folks living with HIV, reporting that they only had condomless sex if a partner was HIV viral load undetectable. Again, for the other two groups, during the HIV negative groups, we don't see any change over time in this behavior. And I think should just point out also for folks that these are cross-sectional samples of our community each year. So this isn't about a change in a person over time. This is more about a change at the community level in terms of the proportion of folks who are reporting these kinds of practices or these kinds of knowledge. And then we have this question about whether they only had condomless anal sex if a partner was on PrEP. And so what we see here is during a significant increase for folks who are not on PrEP, during increasing from basically 5% in 2018 up to 10% in 2021. So still relatively low. But while there's a bit of variation in the numbers here over time, statistically not a trend for the folks who are living with HIV or the folks who are on PrEP. We do see here that guys who are HIV negative and on PrEP most likely to report this behavior compared with the other two groups as well. So that's a little bit around the trends over time. And so the next part around the U equals U impacts is we wanted to specifically talk with folks living with HIV about what U equals U has meant for them and what impact it's had on their lives. So we asked them, has this campaign impacted you in the following ways? So what I bolded here are things that I think generally reflect a positive impact in terms of the U equals U campaign. So 40% of POS folks reported feeling decreased levels of shame and stigma, during 30% said decreased rejection by sexual partners. On the other side of the coin, they said during a third of people said they had increased mental well-being, 30% said an increased quality of sex life and social well-being and access to sexual partners. However, the next items highlighted here, I think, highlight some of the potential detrimental impacts that U equals U has had on folks. And so some people, 14%, said they felt like they had decreased access to sexual partners, and that it increased their pressure to get and maintain an undetectable viral load and increased their pressure to take medications. So in general, the self-reported impacts for equals U are mixed. And I think this speaks to the fact that we often have these kinds of siloed conversations where we talk about U equals U with folks living with HIV, but are not clear, especially from the trends over time, that we're doing as good a job of talking to all parts of our community about U equals U and the science behind that. But this can also go down to provider interactions, and thinking about, are we only talking in HIV care to folks living with HIV about U equals U, or is that something that's coming up in general, broad sexual health conversations? And really this kind of need for a universal campaign that is not specifically just for folks living with HIV to celebrate U equals U, but for all parts of our community. And we definitely see some tensions between these different kinds of antiretroviral-based prevention. So there's some differences for sure between folks living with HIV, those on PrEP and those not on PrEP, and how that kind of shaped changes in knowledge and behavior over time. And I think this really is important as we think about things like serosorting or mixing, and the ways in which during the evolution of these technologies and practices within our community really shape during what actually happens on the ground for an individual in relation to their PrEP status, in relation to their HIV status, in relation to their viral load status. And so while we see generally that knowledge has increased over time and is particularly high in these last few years, the behavioral uptake or the behavioral change that we might consider commensurate with that increase in knowledge doesn't seem to be changing in the same way, and certainly to the same levels. So there's this disconnect to some extent between our knowledge, attitudes, and behavior, which is often things we talk about in health promotion. So that's the end of the 3 chapters in terms of substance use during the testing, HIV self-testing and the U equals U. And I wanted to just remind folks, and also if you've not heard of this, to let you know that we have this data visualization tool. And we have just completed the update of SexNow 2021 into our stats. So now has data from 2015 all the way to 2021 on a bunch of different variables. And so you can go to that by going to cbrc.net/ourstats. And the idea behind this tool, which was really conceptualized by Kiffer Card, who's now at Simon Fraser University, was to really provide easy access to this information in a way that doesn't require people to have to run a stats program or know a lot about statistics to do something. So what you might be able to see, and the text might be too small on your screen, is that you can pick a different variable. So you can look at a general health report, or you could look at testing practices, or you could look at knowledge of U equals U. And that will give it to you at a provincial level or a health region level. You can also look at along the bottom, how things have changed over time for a particular variable. And it will also give you, if you hover over things, a sentence that helps you interpret what the numbers mean. So if you aren't sure if you're interpreting it necessarily correctly, these are the sentences that kind of would mean that you're interpreting it properly. And you can copy and paste those sentences and these figures into grant applications or into campaigns. We encourage people to think about it. If you do really want a deeper dive on any of these things, this is a really good exploratory tool. And if you said, okay, I think we've learned this for our local community, but we want to know a little bit more, please reach out to us. You can contact me. You can contact anyone on the CBRC research team. And we're happy to work with you to try and provide this data in a way that's going to support the work that you're doing locally, or support your efforts to try and secure resources for your work. So if there's anything we can ever do, part of this is our commitment to try and share the data back. And while this tool can do a lot, it certainly doesn't have all of the variables from the study within it. That would just be way too much. But it does have quite a few of what we think are some of the key indicators in the sector related to sex now that we've also measured over time. And so you can also look at subsets of the data if you want to look at particular parts of our community as well. So there's lots of functionality within that, and we are building some resources to also support during learning how to use our stats, because it can be a little bit overwhelming and a little bit of a learning curve to get into. And so you can watch for those on the website as well that will be coming. There's a brief overview there now, but we're hoping to do something a little bit more in depth in the near future. So if you've got any questions about the data, it's always a great place to start with our stats and see if we can get what you need from there. But of course, if you want to have more detailed conversations about anything, or if you're unsure about what you're seeing there, just reach out to our team. We'd be happy to chat. And so I do want to acknowledge all of our participants. As I said, this represented over 25,000 folks who have taken the time out of their days, often on many different years, to participate and complete Sex Now. We are so grateful for that. This work also is absolutely impossible without the community partnerships we have on the ground in many different parts of the country. So many thanks to all of you. And we have many different collaborators and funders, especially over the years, whether that be through the Canadian Institutes of Health Research, Canadian Blood Services, or the Public Health Agency of Canada, among others. Our staff is on the left-hand side here across CBRC, and some folks who work with me at UVic. And then our research working group are kind of research advisors for Sex Now, listed there on the right-hand side. So many thanks to everyone. It is very much a team effort, and I'm always glad to get to be able to be here to speak with people about it, but it really does take a village. And then lastly, just two quick plugs for some studies that we have in the field or ongoing right now. So Sex Now 2022, as I briefly kind of mentioned, we are back in person after many years of postponement due to COVID. We've decided to call this Let's Get Physical, kind of celebrating the fact that we are able to be back in person. I was in Winnipeg on Treaty 1 territory in the homeland of the Métis last weekend with a number of folks from our team and a number of folks there in town, and it was great. The vibe was super positive. There was lots of great energy about getting to be back together as a community to be able to celebrate. We had hundreds of folks complete the survey there. And our team is continuing to go across the country over the rest of the summer to many different communities. And you can find out if we're coming to a community near you by going to cbrc.net/sexnow. And similar to Sex Now 2021, we're providing free HIV self-test kits for those who are 18 and older in the study. And people can use them themselves. In some places, they can use them right on site if they'd like. In others, they can take them home to use. We provide access to peer support, similarly again. And there's a small honor area for completing the study, because we know that oftentimes research isn't the direct primary reason that people go to Pride. And I'm just always really grateful for folks to take a moment out of their days to help us out and provide us with a bit of data that helps with our advocacy work. As folks know, we have used Sex Now data to help advocacy around the conversion therapy ban, as well as about the blood donation ban. And so there's lots of data that we continue to try and put in front of policymakers and government to make things better for the lives of our community. And that's one of the motivations, I think, for a lot of folks. And this year, the survey is in English, French, and Spanish. And so, and we're doing that in partnership and with financial support from CHR Reach Nexus and the Canadian HIV Trials Network. And then if people are also interested and haven't heard, we are currently running Our Health, which is a Canada-wide 2S LGBTQIA+ community health study. And this is open to anyone in our community, regardless of gender and sexual orientation. We've gotten lots of feedback over the years about Sex Now and during the exclusion of women from that study. And so we're excited during many years of working to secure resources and to build the necessary partnerships and relationships that we need to be able to launch this kind of study to have this out there. Our Health is basically looking at the current state of health amongst our community, our whole communities across Canada. There are strong focuses on chronic health as well as on COVID. And there's an option to be able to get a mail home dry blood spot collection kit, which folks can then use to screen to find out if you've ever had COVID, regardless of whether you've been vaccinated or not. And you can also opt in if you'd like to do screening with HIV, syphilis, or hepatitis C. So we're really trying to provide people with increased access to that information about themselves. There's a small honoraria for doing the study. And again, the study is available in English, French, and Spanish. And we have a number of partners, Egal, Enchanté Network, and 2Sims, who are part of this study as well. So if folks have any questions about those, I'm also happy to talk about them, but we don't have data to share yet, but we will at the summit this fall. So just in closing reflections, these are really my key takeaways in terms of the work. HIV self-testing is clearly of interest to and can reach some parts of our community that are underserved. And it's important as we think about programs and services to really think about this reality of secondary distribution. It's different than when we think about testing in a clinical context or a provider context. So that's something that's just important and unique about it. We know that there's multiple and varied motivations for substance use in our community, and that half of our community are not actively seeking to change their substance use. We need better access to GBT2Q-oriented harm reduction and care services for substance use. And in terms of U equals U, while knowledge has increased and we don't see the commensurate change in behavior, and we know that this is influenced by PrEP and PrEP uptake, and that the impacts of U equals U certainly are mixed, and that we need to work and speak with all parts of our community about U equals U. So I think just a few things to also highlight at a kind of higher contextual level. For me, Sex Now, since I began working with the study in 2017, have just been really appreciative for the opportunity we've had to learn and to evolve. And so we've changed the way the study is described. We've worked on evolving the eligibility criteria to try and increase inclusivity and access to the study. And we've been able to do an in-person recruitment in 2018, and I'm so glad that we're back now in 2022. It's going to give us a really nice snapshot of what changed from before COVID to now, and think about as we kind of move forward in our work, who really would benefit from additional support and resources. And the online data collection has been an incredible option to be able to continue doing research through COVID. And as we have this long history with Sex Now of online surveys, it also really helps us look at how things change over time, as you can see from some of those trends we showed around U equals U knowledge and behavior. And in particular, we've really tried to work on making the survey more inclusive for trans men and two-spirit and non-binary people. And as I said, we were in the field last weekend and the weekend before with Sex Now 2022, and we've got really strong participation from non-binary folks and from Indigenous two-spirit folks. And I'm always keen for feedback from those parts of our community in terms of how the survey is for them and how they feel about it. And so far, the feedback has been pretty positive. So I'm glad. As I always say, there is more we can do. And so I'm always keen to hear that. And then just lastly, I mean, some of these trend pieces, while we talk about them, it's really hard to untangle what's also an impact of COVID-19 and what's a trend that would have otherwise occurred within the community. And these really are inextricably tied now, especially as we get into the third year of COVID. So we can try to pull that apart a little bit with some of our data, but it is just a really complex reality. And it changes who we can access because of the ways that our community spaces have been shut down, as well as people's engagement in online spaces has changed. And as well as people's willingness to participate. I think we learned during having a study called Sex Now in the thick of COVID wasn't necessarily something that resonated with people who were actively choosing and managing not having a very active sex life. And although Sex Now is, of course, open to people regardless of whether they're sexually active or not, doing that messaging and that branding doesn't always resonate or reflect the realities that people are living day to day. And we also know that during COVID changes our sexual behavior, our substance use, as we kind of talked about, and also our social determinants of health. And that shapes our needs for and our access to different kinds of prevention and care. And so what's important about Sex Now is that we monitor all of those kinds of things so that we can try to tell a whole story picture of what we need to be doing. So hopefully some of the data we shared today is interesting and valuable. Look forward to the Q&A period now. And of course, if there's other things you want to know about Sex Now, feel free to always reach out. That's my email is at the bottom, and that's Nathan Lachowsky at cbrc.net.
Thank you so much, Nathan, for such a comprehensive review of what we've learned from Sex Now. I know that I'm on the team as well, on the research team, but it's still really, really great to hear it all in such a sequential fashion to just to take a step back and to see how much we've done the Sex Now. So I invite folks again to be putting in questions into the Q&A, and we actually already have some during the course of your presentation that I'll post to you now. So the first question is, do we have any insights regarding the community edition of Test Now, maybe in comparison to the online or Sex Now embedded version, even if it's just preliminary findings?
Yeah, thanks. So for folks who aren't aware, Test Now is this kind of broad umbrella of work that we're doing with the CRHR Reach Nexus to try and advance access to HIV and STBBI testing. So Test at Home, the Sex Now 2021 is kind of one part of Test Now. And then the 2022 June Test Now is also part of that. And then Community Edition was another study that we did, which was in partnership with a number of different agencies across the country, where we provided HIV self-tests to those agencies to use as part of their outreach strategy. And so each agency had their own approach to that. And then we evaluated that a little bit through surveys, both qualitative and quantitatively. And so we're certainly still working through that data. And I think what we've learned is that doing community outreach during the Omicron wave was not easy. And this is one of those pieces where we've got these studies and they're happening at the same time that COVID is unrolling. And of course, no one necessarily planned or hoped for that, but that was one of the pieces. But there's, I think, quite a bit of promise in community distribution. And the people that are reached are different than who we would reach through an online survey and an online service. It's going to take us some more time to get through all of that data just because it's coming from so many different agencies, and in a format that's not as centralized as Sex Now. So in Sex Now, we have the survey that everyone completes across the country and it comes into one database, and that's really nice to work with. So there's not too much more I can share on that other than to say we will be sharing some insights from that, and that we do hope that will also help agencies and other funders consider doing how to potentially shape HIV self-testing distribution programs in the future. So probably not super satisfied with that answer, I'm sure, but that's all I can give you today.
Yeah, and we'll take it. So thank you so much for that. The next question is regarding the finding of the percentage of PrEP users reporting anal sex with HIV positive undetectable partners longer over time. How would you explain this trend generally? So again, the percentage of PrEP users reporting anal sex with HIV positive undetectable partners lowering over time.
Yeah, great question. Okay, so I just want to make sure, just give me 1 second to make sure I've got that right. So so this is a decreasing trend that we saw amongst folks who were HIV negative and on PrEP, reporting that they had any anal sex with a positive undetectable partner. So one of the things that I always find interesting about Sex Now is it always, whenever we share the data, which kind of tells us about a practice, then people are like, well, I want to know why, which is a totally natural question. And unfortunately, Sex Now is only so well designed to do that, because we don't really get at during the full context of what is shaping people's individual practices in a particular sexual moment. What's important about it is that we basically saw it halve. So from 50% of guys in 2018 to 25% of guys on PrEP in 2021. And so to me, I think there's a few things that are likely at play there. One of which I think that's important for us to think about is how much are people talking about HIV status, PrEP status, or viral load status in their sexual encounters. So if someone is on PrEP and they're feeling confident about their PrEP use and their adherence and during the prevention that provides for them, then maybe they're not talking to folks about their HIV status or specifically their viral load status. And so during that would be why we're seeing less people report it, is because they're not actually as explicitly aware of that aspect of their partners because they don't think it's necessary. And I think this is one of those things where we sometimes talk about, like, is PrEP and viral load, do you know what I mean, are both necessary, and this idea of kind of layering prevention strategies versus substituting or alternating them. So to some extent, I think that conversation around how much is the conversation around HIV status and viral load status changing, and we don't really, again, we're not able to hugely tease that apart the same way. But I think that's kind of one thing to consider. What I think is interesting about that trend compared with is that we're not seeing the same shift for guys who aren't on PrEP and guys that are living with HIV. So if that conversation is changing, it's also changing differentially. And so I think that's kind of maybe one piece I would say around that. And then the other piece is maybe they actually just are at a practice level having less sex with undetectable guys. And so if that's the case, during that they have the information, right? And that is explicit, but then the decision making is different. And so those really have different implications, right, for what we want to do about it. And my view generally is that I think there's some great qualitative work that can be done there. And we can try to tease things apart a little bit more in the quantitative, but I do often think that this is kind of where SexNow can help us raise some of these flags and raise some of these conversations. But in general, I think it's a way of an entry point into a greater conversation with your local communities about what's the reality. So you can talk with guys living with HIV about what are they experiencing as they kind of connect with different partners, and for folks who are using PrEP, what's their experiences. And so that's kind of the in that I think in terms of thinking about these data as an engagement tool can provide.
Again, thank you so much for your answer, Nate. And it seems like the Q&A there's like loads of questions and thoughtful questions and discussion going on. But I see that we're coming up on time, so we might be willing to get to one or two more. So the next question is about the section on substance use that you presented. So why the decision to structure the question around substance use and sex to be so widely encompassing of substances, but not asking an additional set of questions around whether people engage with or identify with the PNP scene? So the person just wanted to know like why structure it that way, but they made very clear that it's not a judgment, and we're still very happy with it.
No worries. I see where that question's from, and I'm grateful for it. So thank you. Yeah, I mean, so we wanted to provide this kind of broad-based piece around substance use because I think sometimes our conversations are really narrowed to thinking about just substance use in a sexualized context or just substance use in a particular kind of scene or subcommunity. But we know that substances play a big role in our lives for all kinds of different reasons and in all kinds of contexts. And so that was kind of like the breadth aspect of it. And then we actually do have some questions in the substance use module specifically about whether folks PNP and what drugs they see as, or what drugs they use or see as part of PNP. So we do have some of that data that's just not on the slides today. So I'm excited that other people are excited about that data. And I think that we can connect and think about how we use some of that in lots of the great campaign work that's being done in the community conversations that are happening. I think some of that work is going to take some more community consultation and some more conversation to make sure that we're analyzing it the best way that we can and also presenting it back in the best way we can. So always open to connecting around that. And I know who asked the question, so I will reach out afterwards around that.
And I mean, I invite everybody to, as Nate had mentioned earlier, to reach out to him or to anybody else in the CBRC team if there are questions that come up after this. So I think we do have time actually for this last question in the Q&A. So it's again about the substance use section that you presented. So did 2S LGBTQ plus folks feel barriers accessing NSP programs or safer inhaling programs? And if so, was there any specific causes?
It's a great question. And Naomi, I don't want to put you on the spot, but I know you've been working with some of these data lately too. So if you have anything you want to add, feel free. I think that what I'll just say as a bit of context, if this gives you a moment to prepare too, Naomi, is that I think that one of the big things that I would say at a high level is that the amount of folks who are reporting using different kinds of substances and the amount of folks who report using any different kind of support broadly around substance use, whether that be harm reduction or support, there's a big gap there. And part of that is because some people may not want it or feel the need for it. And so I think there is, and some of that is that we're as a sector, do you know what I mean, in terms of the HIV response, if we think of it that way, the HIV sector hasn't always done that work for gay men and our communities more broadly. And so I think sometimes it's just been that we've had this partitioned approach to HIV, which has meant that during substance using generally means injection drug use, and then there's a group that is targeted that way, and then we separate it out. And this overlap often, I think folks that are living at that reality are forgotten or and underserved by different groups. So in general, I think there's this big gap that we see across the kind of board for all of those pieces. And we did see that more people wanted access to those programs. So I think that's kind of one of the things that was articulated back to us. In terms of specific barriers, I honestly can't recall off the top of my head. So, Naomi, I don't know if you have anything you want to add to that or not. You don't need to, but you can also follow up with via email and we can look at some of that, I think.
Yeah, I completely agree with everything you said. Maybe just one thing that I'll add is that in terms of the types of services and resources that we found that were most requested were generally like ones that were about harm reduction. So whether that was like safe supply, safe injection sites, needle exchange sites, those were some of the most requested resources. And those were even higher when we looked at specific groups of different groups of people that use substances. So among people who use meth or who inject drugs or who use opioids. So I think there is, as Nate said, there's like this types of differential need for services related to substance use, but I think we need to look at the data a bit more. It's also a bit harder to say exactly what types of barriers people experience because it's not really able to be captured in the survey in the same way. So again, just calling back to what Nate said about potentials for qualitative work for what exactly people say are barriers and why there is like a reported, why there was a lower reported access to services. But a great question. So we hope that you'll be able to find some of the work that comes out of that pretty soon. So thank you everybody for such engaging questions and for, again, to Nate for going through so much of the incredible work that's going on with Sex Now data. We hope that you found this presentation to be informative and that you have a lot to think about. And again, if you have questions afterwards, please feel free to reach out. There will also be an evaluation feedback form that you can offer just your general thoughts about this session in particular, what you thought, what you think we can improve, so we can continuously be offering the best types of knowledge translation and community outreach to folks who would really benefit from this research. So with that all said and done, Nate, unless you have anything else you'd like to say in closing for this webinar, again, thank you everybody for joining and spending an hour with us. And we hope to see you on the next one.
Thanks, folks. Keep well.